Trust in clinical trials is not built in consent forms. It is built in relationships. We're Sciana Cohort 7, Mridul Agrawal, Raquel Correia, Judith Dyos, Claudia Schade, and Andreas Welker, exploring how to rebuild trust in health communication and improve access to clinical research. Today, we hear Elizabeth's lived experience perspective as a cancer survivor and health researcher. This AI-generated interview is based on written notes. We're asking, what would change if clinical trials were designed not around an abstract patient, but around real people, real burdens, and lived experience as evidence that matters?
Welcome, Elizabeth. Thank you very much for joining us and for sharing your perspective. Today, we would like to talk about access to clinical trials, trust, and what clinical research looks like from the patient's point of view.
Thank you for inviting me. I'm happy to contribute. But I should say from the start that I'm speaking from a very specific perspective. I'm a cancer survivor, currently in the endocrine therapy phase, and that is what brought my interest in clinical trials closer to my own life. I'm also a researcher in the health field, so my experience is probably not the experience of an average patient.
That is exactly why your perspective is so valuable. You are speaking both as someone with lived experience as a patient and as someone who understands research from the inside. How did clinical trials first come up in your own treatment journey?
In my case, it was my oncologist who raised the topic. We were discussing the endocrine therapy phase of my treatment, and she mentioned the possibility of clinical trials involving new endocrine medication. So the entry point was not a public campaign, a registry, or something I found myself. It came through the clinician.
So the clinician plays a central role.
Absolutely. From my perspective, almost everything depends on the clinician. The clinician has to be aware of ongoing trials, interested enough in research to think beyond standard therapy, and connected enough to know where a patient might fit. As a patient, I would not necessarily know what is available or relevant unless someone tells me.
And from the patient's side, what makes trial participation feel possible or not possible?
Several things. First, the practicalities matter a lot. How close is the research center? How many additional tests or appointments are required? How long does the trial last? Patients already have a regular schedule of medical appointments, and an additional trial can mean more travel, more time, and more energy. Second, there needs to be a perceived benefit. For example, could the treatment have fewer side effects? Could it be more effective? I would call that the perceived return on investment for the patient. And third, trust matters. I would need to trust the seriousness of the research institution.
That idea of return on investment is interesting. It sounds quite rational, but also very human.
Yes, patients are often exhausted. Especially in cancer treatment, you already go through so much. If a trial means even more appointments, more uncertainty, and more organization, then the question becomes, what is the reason to do this? What could I gain? And is it worth the additional burden?
Do you think certain groups of patients are more likely to participate in trials than others?
My answer is more anecdotal than data-based, but I would expect that trial participation requires some degree of research interest, trust in science, and confidence in navigating the system. That may correlate with education, income, culture, gender, or other social factors. But again, I am careful here because I am not basing this on a data set.
You mentioned trust. What helps to build trust in conversations about clinical trials?
For me, the foundation is an already established doctor-patient relationship based on trust and respect. Trust means that the doctor tells me the truth, including unpleasant truths. Respect means that the doctor does not talk down to me and does not try to push me into something. Instead, she presents options in a way that allows me to make my own informed decision.
And what would undermine trust?
There should never be the impression that the clinician personally benefits from my participation, whether economically or career-wise. Even the suspicion of that can be damaging. Recent scandals, for example, around a professor in Switzerland, or similar issues with spine implants, shape how people think about medical research and medical authority.
So conflicts of interest, or even perceived conflicts of interest, can have a real impact.
Yes, and this connects to a broader cultural issue. There is still, in some places, a gods in white culture in medicine. There is not always enough of an error culture, and not enough communication on a level playing field. For me, that is where responsibility starts.
You use the phrase level playing field. What does that mean in your own care?
In my case, my conversations with my oncologist were quite unusual. I have a background in health research. I have a PhD and a habilitation in health, and therefore we could discuss science, data, research, and trials throughout the treatment pathway. But I am very aware that I am not a standard patient.
So your experience raises the question, what happens to people who do not have that background?
Exactly. In one of my presentations on lived experience, I used the example of a 55-year-old woman with first-time breast cancer. That is what the system might see. But what the system might not know unless it asks is that this same patient may have years of experience with her own body, previous conditions, surgeries, family responsibilities, and sometimes even scientific or professional knowledge. Lived experience is often invisible unless clinicians make space for it. And how did clinicians react to you as an informed patient? Almost every doctor was at least initially irritated to have an informed patient in front of them. Someone who asked questions, claimed the right to an informed decision, and wanted an equal voice in the process. Mentioning my PhD and habilitation often helped. But then the obvious question is, what does everyone else do?
That is a powerful question.
Yes, because patients should not need academic titles to be taken seriously.
You also gave a concrete example involving a medication plan. Can you describe that?
Yes, I received a medication plan that included information which was frightening, unclear, and not organized from a patient perspective. There were references to being high risk that had never been explained to me. Medications that had to be taken, could be taken, or should not be taken without consultation were mixed together. Some medication names differed from the names on the packages. When I reacted, the first response was basically, "But this is not meant for you." Which is absurd if the document is handed to a patient.
What happened next?
The document was reworked. Notes from the nurse and from me were included, and eventually the cancer nurse produced a clearer version. It was not perfect, but it was much better. The unnecessary and scary information was removed, medication names were clearer, and there was a better separation between what had to be taken, what could be taken, and what should not be taken without consultation.
What is the lesson from that example?
Very simple. If a document is meant for patients, show it to at least one patient before issuing it. And listen when patients say something is unclear. In this case, the positive point is that they listened, they reacted, and they asked the person who spends the most time with patients, the cancer nurse, to redo it.
That links directly to trust and accessibility. Often the problem is not only whether information exists, but whether it is understandable and usable.
Exactly. Information that is technically correct can still be unusable for the patient. And if even someone like me, with a scientific and clinical background, finds it incomprehensible in that moment, then we really need to ask what happens to others.
What should healthcare professionals take from your experience?
I would say, when a patient seems demanding, eccentric, cranky, or difficult, take a breath. Then take another one. Open your mind and, ideally, your heart. Listen for at least 60 seconds. Patients may know something about their body, their symptoms, their treatment history, or their mental state that matters. It may matter for the therapy, for the course of treatment, and for healing. It may also save resources.
So lived experience is not just a nice add-on, it is a resource.
Yes, it is seriously underused. Not only the lived experience of patients themselves, but also that of relatives, nurses, physiotherapists, and others who are close to the treatment journey. If health systems are facing scarce resources, they cannot afford to ignore such a resource.
How would that apply specifically to clinical trials?
Clinical trials need to be discussed in a way that respects the patient's reality. Practical barriers, energy, travel, fear of side effects, perceived benefit, and trust in the institution all matter. Also, the patient needs to understand why the trial is relevant to them. It should not feel like a favor to the system. It should feel like an informed option.
And what would make you hesitant, even if you generally have a positive view of clinical trials?
If my own doctor were directly involved in the trial in a way that created a potential personal benefit for her, I would be more hesitant. Otherwise, my view of clinical trials is positive. But transparency is crucial.
Do media narratives play a large role in your own view?
Not very much, except when scandals are reported. In my perception, clinical trials are not usually discussed much in the media, but scandals can be very influential because they reinforce fears about conflicts of interest, lack of accountability, and unequal power between doctors and patients.
If you had to summarize your message for healthcare leaders, researchers, and trial teams, what would it be?
Do not design clinical research around an abstract patient. Design it around real people. Ask what the trial means for their daily life. Ask what they need in order to make an informed decision. Ask whether the information is understandable. Ask whether practical participation is realistic. And take lived experience seriously.
That is a strong message. Clinical trials are often discussed in terms of recruitment, representativeness, and evidence generation. Your perspective reminds us that accessibility starts much earlier in trust, communication, respect, and practical feasibility.
Yes, and perhaps the most important point is that participation should never depend only on whether one clinician happens to be interested, informed, and connected. If access to trials depends too heavily on individual clinicians, then opportunities will not be distributed fairly.
Elizabeth, thank you. Your reflections show that trust in clinical trials is not built by information alone. It is built through relationships, transparency, practical support, and a willingness to treat patients as partners.
Thank you, Cedric, and I hope that more health systems will begin to see lived experience not as a problem to manage, but as a resource to integrate.
Thank you for listening. This conversation is part of our work on trust, accessibility, and participation in clinical research. The question we take away is simple. What would change if lived experience were treated as evidence that matters?